We're blasting through central venous catheterization, CRBSI management, thoracic drainage, peritoneal drainage, and finally, surgical airway access. Okay, kicking things off with Section 1, Central Venous Catheterization. Here is your first absolute rock-solid exam rule. If there's venous thrombosis at the affected site, that is a hard contraindication for catheter placement. No exceptions. You've got to memorize this strategic breakdown of access sites. The internal jugular, that's your go-to for coagulopathic patients because, hey, if they bleed, the vessels are readily compressible. Now, the subclavian is great for minimizing infections, and patients generally find it the most comfortable, but do not use it if your patient has renal failure. You're risking central stenosis. And the femoral vein, strictly for emergent CPR resuscitation when you're out of options. Speaking of coagulopathy, know your numbers cold. A platelet count under 50,000 per microliter or an INR over 2, those are relative contraindications. If it's an elective procedure, you absolutely need to give blood products prior to insertion. If that's simply not feasible, stick to the internal jugular. It's your safest bet.
So how do we target the anatomy for the internal jugular? Obviously, ultrasound is the standard now, but if you're using the landmark technique, aim for the apex of the sternocleidomastoid triangle. That's about 1 centimeter lateral to the carotid pulse. Angle your seeker needle at a 45-degree angle, pointing right toward the ipsilateral nipple.
Let's talk mechanics. Across all these sites, the Seldinger technique is universally applied. It's an incredibly elegant 5-step process. First, get venous access with your needle. Second, slide the flexible guide wire through. Third, and this is key, pull the needle out while keeping strict control of that wire. Fourth, pass your dilator over the wire to open up a tract. And fifth, thread the catheter into place and remove the wire. Seriously, whatever you do, never ever let go of that guide wire. If you're stuck using the femoral approach during trauma or code, visualize this anatomy. The vein is sitting precisely medial to the femoral artery pulse, just below the inguinal ligament. You're going to introduce your needle medial to that pulse, angle it 30 degrees, and point it cephalad. Moving right along to Section 2, Preventing and Treating CRBSIs, you can literally slash central line infection rates by up to 66% just by strictly adhering to a bundle: hand hygiene, chlorhexidine-based skin prep, maximal barrier precautions, reviewing daily if the catheters even needed, and avoiding that femoral vein. But what happens when an infection does occur? You follow the gold standard algorithm. The overarching rule here is that if you've got bacteremia, you generally must remove the indwelling catheter and treat with systemic antibiotics. However, take a look at the left side of this workflow. There are a few highly specific salvage scenarios. Notice these strict pathogen-specific rules because they will test you on this. Staph aureus, enterococci, gram-negative bacilli, or candida. Mandatory removal. End of story. Don't even think about it. But if you're dealing with coagulus-negative staphylococci in a patient with limited vascular access, you might actually try to salvage a short-term catheter. You'd use broad-spectrum systemic antibiotics combined with antibiotic lock therapy for 10 to 14 days.
All right, shifting gears to Section 3, Thoracic Drainage Procedures. Thoracentesis and tube thoracostomy are your absolute go-to interventions for getting pleural fluid, blood, or air out of the thoracic cavity. Listen closely because this exact number pops up all the time. If you're doing a diagnostic thoracentesis, to figure out why an effusion is there, you literally only need to drain 20 to 30 milliliters of fluid. That tiny amount is plenty to run your LDH, protein, pH, glucose, and cytology. Now for tube thoracostomy. This is the cardinal rule of chest tubes. Look at how the instrument is positioned here. You absolutely must always advance your needle or clamp over the top of the rib. Why? Because the neurovascular bundle hides right under the inferior margin of the rib. Going over the top is literally how you avoid causing a massive iatrogenic bleed. The sequence for a chest tube is super structured. Find the safe triangle and go in at the 4th or 5th intercostal space, right at the anterior axillary line. Make your skin incision, bluntly dissect an oblique tract over the top of that rib, and pop through the pleura. Then get your finger in there to manually lyse any adhesions and verify you're actually in the pleural space. Finally, point the tube up toward the apex for a pneumothorax, or aim it basally and posteriorly if you're draining fluid, like a hemothorax.
Section 4, Peritoneal Drainage, or paracentesis. This is our workhorse for diagnosing infected ascites or therapeutically draining tense ascites that's causing respiratory compromise.
Watch out for exam traps here regarding contraindications: previous abdominal surgeries, dilated bowel from an obstruction or ileus, Pregnancy and coagulopathies, these are relative contraindications. It doesn't mean you absolutely can't do the procedure, but it mandates extreme caution and the use of ultrasound guidance so you don't cause a catastrophic visceral injury. When it comes to needle insertion, you have two options. Contrast the midline approach against the lateral approach. With the midline approach, inserted midway between the umbilicus and pubic symphysis, you have to be super careful because air-filled bowel tends to float dangerously near the surface on top of the ascites. The lateral approach is generally much safer. You're targeting the left or right lower quadrants lateral to the rectus abdominis muscle.
Okay, section 5, surgical airway access. This is the emergent stuff. When your patient is crashing and translaryngeal intubation completely fails, you must immediately establish a surgical airway. Lock this anatomy into your brain right now. The life-saving emergent incision happens exactly here, at the cricothyroid membrane. You can palpate the thyroid cartilage, the Adam's apple, above it, and the cricoid ring just below it. That membrane connecting the two, that is your rapid entry point. So in a high-stakes emergency cricothyroidotomy, you grab that cricoid firmly with your non-dominant hand, make a vertical skin incision. Then, with a blade, make a small 3 to 5 millimeter transverse incision straight through that cricothyroid membrane. Widen the tract with your scalpel handle or a clamp and drop your tube in immediately. Now, contrast that chaotic emergency procedure with a percutaneous tracheostomy, or PT. These are strictly elective, non-emergent procedures. You do them safely at the bedside in the ICU so you don't have to transport a critically ill patient, and you're relying heavily on bronchoscopic guidance. Just remember, an unstable cervical spine is a major contraindication here. Across all these airway procedures, you need to be hyper-vigilant for the #1 complication, creating a false passage. You'll know instantly that you messed up because you'll have an absence of breath sounds, a total lack of end-tidal carbon dioxide on your monitor, and the rapid development of subcutaneous emphysema. Before we wrap up, I want to bridge a concept across our fluid drainage topics. You always have to respect massive fluid shifts. Removing too much fluid too quickly, whether that's from the thorax during a thoracentesis or from the abdomen during a large volume paracentesis, can lead to severe hemodynamic instability and a specific complication known as re-expansion pulmonary edema. Drainage has to be controlled. All right, we've just powered through every high-yield exam point, algorithm, and anatomic landmark in this explainer. You've got the structural logic mapped out in your head, but the real test isn't just knowing the facts. It's being able to apply this precise step-by-step logic effortlessly at the bedside when every single second matters. Are you ready to deploy it? Review these concepts, lock in the anatomy, and trust your training. You've got this.